Hi everybody, let's start with part 2, management strategies. So we know how important the skin is, and from a personal perspective, you know when your skin is too dry, how uncomfortable that can be. So it's important to maintain skin hydration to prevent and treat skin conditions. If there's too much fluid in the skin, then the bonds of the cells have a difficult time adhering, and this barrier can break down. And then if skin is too dry, it can crack and again break down the barrier. Something that we all do frequently to help our skin is bathing. It's important to do that with lukewarm water long enough for the skin to become moisturized. It's important to pat the skin dry, not vigorously rub the skin and remove all the moisture. There are some environmental considerations we need to take into account when talking about the hydration of our skin, and that includes humidity. Excessive humidity greater than 90% or deficient humidity less than 10% can be a disruption of the skin. And we know that when there's too much moisture on the skin and the skin is in touch with each other, we can have macerated skin. This type of condition responds better in less humidity, so there's not as much moisture in between the skin or that sweating. If you have a child that has itching from excessively dry skin, this can be relieved often by increasing the humidity in the air, such as using a vaporizer or a humidifier. In hot temperatures as well, itching can be alleviated by air conditioning. That cool air across the skin can help the skin not to be as dry. We also know that water intake plays a big role in maintaining skin hydration, and it's important for kids to drink plenty of water. The type of products that we put on our skin are important. So most individuals, you may use soaps, oils, or colloids. It's important to make sure that those are non-allergenic and mild. Moisturizers and lubricants are applied to help retain water to the skin. So it's important to educate your parents that just to pat dry the skin after they've given a bath to their child, and then apply their moisturizer or lubricant. And as that is working into the skin, then it's taking that thin layer of water that was left on the surface in with it, versus having a very dry skin before you put your moisturizer or lubricant on. So there may be a time when a child has a skin issue that needs a little further attention. So there are different types of dressings that are available. First one we're going to talk about are wet dressings, and those help to moisturize the skin. They decrease itching. They might remove any crust that are there by not allowing them to be so dry. The dressing should be moderately wet but not soaking, and it should be more of a lukewarm temperature, applied for about 10 to 20 minutes 2 to 4 times a day over 2 to 3 days. Saline can be used with this. Burrows solution can also be used. Another dressing type is occlusive dressings, and this helps decrease water evaporation from the skin and helps the area to stay hydrated. It also helps in the absorption of topical medications. Plastic wrap can be placed over the affected area as a home remedy after hydration and applying this cream or the ointment. It's important that these dressings not be left on any longer than 8 hours. Some other considerations if your child is having skin issues is to avoid irritants such as wool, sweat, or saliva, and then also be aware of allergens that can be found in common foods such as milk, eggs, wheat, tomatoes, citrus, chocolate, fish, nuts. All of these can be common food allergies that may be seen with issues with the skin. Next, let's talk a little bit about protection of the skin in the sunshine. We know that all skin needs to be protected from UV light. Daily application of a sunscreen with an SPF of 30 is basic. If when applying other sunscreens, it's important to apply approximately 30 minutes before exposure to allow the sunscreen to bind with the stratum corneum cells to offer that barrier. When kids or adults are out playing, perspiring, or washing, it's important to reapply frequently, and there's never a substitute for sun protection other than being inside. So encouraging parents to protect their kids' skin is very important. Next, we're going to talk a little bit about treatment of skin conditions. Most derm conditions are treated with topical medications. And one of the goals of these medicines is to restore hydration, to help with the symptoms, help reduce any swelling, and protect the skin, reduce any scales or debris that might have accumulated, cleanse the skin, and get rid of any organisms that are causing the problem. When deciding what product to prescribe or recommend for the child, it's important not only to consider the medication for the skin condition, but also how it's been prepared and how it will be transported into the skin, including stabilizers, preservatives, and perfumes. There's a great Pearl section, snippet section, box 37-5, which gives some more information on preparations of topical medications. I encourage you to look at that in the blue book on page 989, but box 37-5. It's important to know if you have individuals that are sensitive to certain preparations, to certain fragrances, etc., before you decide to prescribe a certain medication, because you don't want something that the route that the medicine is being delivered in, whether it's how it's prepared or any additives that are used for stabilization, could make your initial skin issue worsen. There are several agents that can cause sensitivity to the skin. Those can include such as lanolins, parabens, propylene glycol, neomycin, those things that are in your triple antibiotic ointments. So there are certain guidelines to use when using preparations like this. So if you have an acute inflammation of the skin, it's best to use wet dressings, powders, suspension lotions, alcohol or water-based lotions, or aerosols. If there's chronic inflammation, use creams, oil-based lotions, or gels and ointments. And as we talked about, the patient's tolerance for these preparations is important on choosing the route that the medication will be absorbed, and then also taking into account whether the individual lives in a dry or humid environment. One thing to remember is all topical medications, except powders, have better absorption if applied to the skin immediately after it's been saturated with water. And using an occlusive dressing, like we talked about previously, enhances absorption of the medication. When you're instructing your parent on how to use this medicine, application of a topical medicine is best done in one direction, preferably along the hair follicles, and is better without rubbing and applied with a single motion. It's also important to use an adequate amount of the product, but it doesn't need an excessive amount. Other items that you may see are antibacterial agents, and these can be found as soaps and topical anesthetics that are used to cleanse the skin and reduce bacteria on the skin. There are times when topical antibiotics may be used to treat minor skin infections, but it's important to note that neomycin should be avoided because there is a high incidence of contact sensitivity with it. If you do have a more severe infection, oral antibiotics may be necessary, and if there's concerns for MRSA, it's important to do a culture on sensitivity to rule that in or out. Other medications that you may use are antifungal agents. Many of these are located over the counter now, and you will see that there are oral antifungals that can be used for the hair and nail infections or refractory skin infections. The use of oral agents in the antifungal line should be used with caution with kids. Many of these drugs are not approved by the FDA for pediatric use. Another line of agents are your antivirals, and they're used to control cutaneous herpes infections. Oral antivirals such as an acyclovir can shorten the course and be used for treating recurrent issues. And also in the management of wart therapy, you're looking for agents that are going to destroy the keratin. And these can include salicylic acid and lactic acids. Could also be liquid nitrogen and trichloroacetic acid. We're also going to talk about anti-acne agents, and these are topical keratolytics, and they relieve the follicular obstruction that is seen with acne. First line are your benzoyl peroxide retinoic acids, and you may combine those with other agents if the condition is moderate to severe. Topical antibiotics are very effective in controlling acne. Clindamycin, erythromycin, and sulfacetamide have fewer side effects and are commonly used. Systemic antibiotics are effective in treating inflammatory acne, and they work by decreasing the population of the Propimedion bacterium acne organism that will be found on the skin. There is also treatment for acne that is used for females with estrogen containing oral contraceptives along with an androgen for treating acne, such as an orthotricycline or Yaz. There are several out there that have been approved by the FDA for acne. And then also phototherapy is also an option for acne. Anti-inflammatory agents include steroids, and these are used to decrease inflammation, decrease itching, and help vasoconstriction without causing widespread systemic effects that can often be found with oral steroids. The key to using steroids is to be familiar with the potency of each of the steroid medications. And it's important to know a few in the low and the medium and the high potency steroid classification. There is some thought that brand name preparations are more consistent based on their base and potency. Ointments are more potent than creams. Creams are more potent than lotions. And foams are very effective in hairy areas. And then absorption is enhanced in areas that have been traumatized. So be sure and take all of those factors into consideration when prescribing topical steroids. On table 37-1, there's a great table on different types of topical steroids, talks about their different classes, their generic and their trade names, and then the potency of each of those. It's recommended to always use the lowest potency available and use them sparingly and for the shortest period of time, and that primary care providers should rarely use high potency topical steroid preparations. If you are prescribing for the face, the buttocks, the groin, or the axilla, it's important to prescribe a low potency steroid only, as there's potential side effects of causing issues with the skin, such as atrophy, stria, increased fragility of the skin, and hypopigmentation if you are going with stronger medications. If there's an acute situation that you think a topical is not going to be sufficient for, oral glucocorticoids can be prescribed, such as a prednisone, and are only used for a short course. Continuing with our medications, we have antipyretic agents, and those are antihistamines that help with itching, and they can also be used for sedation, especially if a little one is having issues with itching at nighttime. These may include hydroxyzine, cetirizine, fexofenadine, and diphenhydramine. Benadryl topically should be avoided because of the possibility of some contact sensitization to the area. We also have a line of topical calcineurin inhibitors, and these are immunosuppressive nonsteroidal anti-inflammatory topical meds that are used for short-term or intermittent long-term treatment of atopic dermatitis when regular therapy has not been effective. These medicines can be expensive and are not to be used in children younger than 2. We'll talk about this more in Chapter 25. Another line of medications you may use in practice are scabicides and particulicides. These are medications that are toxic to mites and lice. And then hair and scalp preparations. There's several out there that are used for infection, psoriasis, dandruff, and dermatitis. It's important to feel comfortable with some of these. Okay, let's talk a little bit about bacterial infections of the skin and subcutaneous tissue. First thing that we're going to talk about is impetigo. It's a contagious bacterial infection of the superficial layers of the skin. It comes in two forms: non-bolus, which you see with honey-colored crust, which you'll find in about 70% of your patients that you see, and then a bolus. You can see an example of both of these on figure 37-4. This is an error. It says 27-4, but it's figure 37-4 in the book. We know that impetigo is usually caused by group A streptococcus, strep aureus, or by MRSA, and often these can be cultured from an impetigo lesion. Staph aureus is the most common pathogen. Non-bullous impetigo usually follows some type of skin trauma, such as a bite or an abrasion or a varicella or some other skin disease, maybe an atopic dermatitis. The bullous impetigo occurs sporadically and develops on intact skin and is most commonly seen in infants and young children. Bacterial colonization of the skin can occur several days to months before the lesions appear, and then the organism is typically spread by autoinoculation via hands, towels, clothing, drainage from the nose, or droplets. Impetigo occurs more frequently with poor hygiene in the summer months when it's warm, humid, moist climates, and in lower socioeconomic groups. Just to note that the streptococci that causes pharyngitis rarely can cause impetigo, and vice versa, but you can get secondary bacterial infections of the underlying skin. So as always, it's important to get a history. We want to know if there's been any itching, any spread of the lesions to surrounding skin, or were there any earlier skin disruptions in the area. Has there been any weakness, fever, or diarrhea seen with the bullous impetigo? On physical exam for the non-bullous, you may see 1 to 2 millimeter reddened papules or pustules. They may progress to vesicles or bulla, which rupture and release a honey-colored crust. The bullous areas are large and flaccid. They have a thin wall, and they may be oval in shape with blisters or bulla, and then they can rupture. Lesions are common on the face, the hands, the neck, the extremities, and the perineum, and you also may note satellite lesions near the primary site, although they can be anywhere on the body. And there can be regional lymphadenopathy near these lesions. Diagnostic test to help confirm this would be a gram stain and culture. Some differential diagnoses might include herpes simplex, varicella, eczema, contact dermatitis, tinea, scabies, etc. Management includes topical antibiotics if superficial, non-bullous, and localized. Oral antibiotics may be needed for multiple lesions or spread of infection to family members. Topical treatment alone may include bacitracin or polymyxin B or neomycin, but there's been increasing resistance to traditional topical antibiotics, so mupirocin and retapimelin are considered better choices for topicals. As we mentioned, oral antibiotics are recommended for multiple lesions or non-bullous impetigo with spread throughout the family, and you treat for Staph aureus or S. pyrogenes, as they may be in coexistence as well, and some of those treatments can be found on page 993 in the Blue Book, and these would include cephalexin, augmentin, dicloxacillin, clindamycin, etc. If you note bullous impetigo in an infant, it's important that they receive parenteral treatment with a beta-lactamase resistant anti-staphylococcal penicillin, and this would be methicillin, oxacillin, or nafcillin. If your little one has no response in 7 days, then you need to swab beneath the crust and do a gram stain culture and sensitivity. And community-acquired MRSA should be part of your differential then. This organism may be susceptible to clindamycin and Bactrim. It's important to educate your parent and child about cleanliness, hand washing, and the spread of disease. They need to be out of daycare or school until treated for at least 24 hours. And then a follow-up appointment should be encouraged in 48 to 72 hours if symptoms not improved. So some complications of impetigo could include cellulitis. You could have lymphangitis. There could also be the staphylococcal scalded skin syndrome, SSSS, which is a blistering disease that results from circulating epidermal toxin cells producing Staph aureus. And this is most common in neonates, and it's called Ritter's disease. Patient education and family education is very important. Thorough cleansing of any breaks in the skin helps prevent impetigo. It's important to let them know that there may be some pigment changes to the skin post-inflammatory that could last weeks to months. And then also, as we talked about previously, the patient should not return to school or daycare for 24 hours after treatment has been initiated. Let's talk briefly about cellulitis, which is a localized bacterial infection that involves the dermis and the subcutaneous layers. It's commonly seen after an issue with the skin surface, maybe from an insect or an animal bite, trauma, or a penetrating wound. Cellulitis is very common in kids with diabetes and immunosuppression. It can be seen periorbital, perivaginal, perianal, buccal, or involving a joint or an extremity. Streptococcus pneumonia and Staph aureus are the most common causes. Buccal cellulitis and infections in the joints are most commonly caused by the H. flu virus and occur in children anywhere from 3 months to 3 years old. When taking your history, it's important to note if there's been any previous skin disruptions at the site, any fever, pain, a malaise, irritability, not willing to eat, chills, recent sore throat or upper respiratory infection, any anal itching, stool retention, or constipation. On physical exam, you may notice that there's a reddened, indurated, tender, swollen, warm area on the skin. It may be blue to purple tinged if it's associated with H. flu. There may be regional lymphadenopathy. It may be well demarcated perianal redness. It may take on an erysipelas appearance and appear as an orange peel with tender, bright red, sharp margins. Diagnostic studies, most are treated empirically. If you have a child that's ill appearing, doing a CBC and a blood culture is warranted. If pus is noted, then culture. Your differential diagnoses may include pressure erythema, giant urticaria, herpetic Wardlow, or diaper dermatitis. Management will include hospitalization if the child is febrile and looks toxic, and then the antibiotic therapy would be dependent on the organism. It's important, though, that antibiotics be started in a prompt manner. If a strep infection is suspected, then penicillin is the drug of choice. If the organism is thought to be staph, then an IM dose of ceftriaxone followed by dicloxolin would be started, and if the organism is suspected to be H. flu, then augmentin would be recommended. It's important to follow up in 24 hours to assess the response and to observe if there's been any toxicities, and then continue daily visits with the child until recovery. It's also important that you educate the parent on the steps to take to contact the provider or to return for an urgent visit if infection is not improving or getting worse. Complications could include necrotizing fasciitis or toxic shock syndrome. Patient education and family education includes thorough cleaning of any break in the skin to prevent cellulitis. Keep bites, scrapes, and rashes clean and bandaged until healed. Frequent hand washing is essential. And it's also important to educate parents that perianal spread can occur through shared bath water. Let's finish up with folliculitis and furnicles, and then we'll end this one. Folliculitis is a superficial bacterial inflammation of the hair follicles, in contrast to a furnicle, which is a deeper infection at the base of the follicle and of the dermis, and is often considered a boil. The most common organism is Staph aureus, as is Pseudomonas aeruginosa, which is associated with hot tub folliculitis, and then E. coli has also been implicated. There is a higher incidence of folliculitis and furnicles in males than there are in females. Clinical findings and your history, you need to assess for itching, is more often seen with folliculitis, and tenderness with a furnicle. As we talked about, any hot tub exposure, any irritating surface agent. You may see occasional fever, malaise, and lymphadenopathy. On physical exam, you may note a discrete reddened 1 to 2 millimeter papular pustule on the inflamed base near the follicle. It can be found on the face, the scalp, the extremities, the buttocks, and the back. You may note some nodules with the furnicles. You can also have pruritic papules and pustules that may take a deep red-purple appearance in nodules in areas underneath bathing suits. Diagnostic studies would include a gram stain culture if needed. Your differential diagnoses could include candida, tinea, acne, and chemical folliculitis. Management includes warm compresses after bathing to affected areas. A topical paralytic such as a benzoyl peroxide, 5 to 10% twice a day, could be beneficial, especially if this is a chronic or reoccurrent condition. If antibiotics are needed, then an anti-staphylococcal beta-lactamase resistant antibiotic such as a dicloxacillin can be used, or a cephalexin. It's important to review for good personal hygiene habits and avoid shaving until resolved. Follow-up treatment in 1 week for folliculitis, and in 1 day if there's a furnicle or an abscess, as there may need to be an incision and drainage. Complications may include a deep abscess formation, or carbuncles can occur. Also, with the importance of good hygiene, antibacterial soaps may help the spread to other household members if folliculitis or furnicles are found on the child. So that will end this section, and I'll be right back.